Okay. Well, welcome everybody to our December 1st Social Needs and Health Equity Learning Circle. I am Ginny Weir. I'm the CEO of our Foundation for Healthcare Quality, and I've been really lucky to help lead our state's Bree Collaborative for the last 8 years. And I am joined by Nick and Amelina of Foundation staff, and we're all grateful for your presence this morning. So our work around our population's social needs has been generously funded by the Washington Healthcare Forum. And this group is a coalition of senior leaders from major hospitals, healthcare organizations, different health plans, physician practices, and trade associations. And really with them, we're questioning how we can all within these varied and siloed systems help to better meet the whole of the person who comes to us for clinical care. And so answering this question has really been at the root of our work and has been the inspiration for our convening throughout this last year to help develop our clinical guidelines. One of our key members of that work group was Janet Tufte, with more than a decade of experience collaborating with communities, identifying social determinants of health, addressing disparities in health equity through in-person and digital project development and implementation efforts. Janice brings her own lived experience as well as her willingness to push back against that oh so common refrain of that is just the way things are. So Janice, thank you for being with us today, and I will turn it over to you.
Great, thank you. Thank you for having me here today. As Jenny mentioned, my name is Janice Tufte, and that's my website. And basically, I wanted to title my slide, Keeping Hope Alive, because I've had many touch points with the social determinants of health, and I'll share some of them. But basically, connecting strengths to challenges and resiliency with supports will be very beneficial in outcomes. Next slide, please. So new to needing help. When I experienced homelessness back in the 90s, I really had no idea what to do, where to go, where to turn. And I had money stolen, so I had nothing. I went and stayed in a shelter downtown. And fortunately, I learned quite a bit from other individuals that were in the shelter as they were able to share some of the ins and outs. For instance, there was a women's shelter I was not aware of, as well as how to get a bus pass. So social workers and counselors are often overwhelmed, and if they spend the amount of time they should with individuals, similar to a medical, a clinical visit, they were, weeks out. So all of these intersect, right? So I just wrote out squares or domains that I thought were, that really could show some of the issues around social determinants of health. And often we don't think about the internet, but it's very, very serious today, where people really need access to, data on their phone. Is how they contact their doctors, how they contact their family. And medical legal field is really growing steam around the nation around complex care. Individuals who've had evictions or might have a minor marijuana charge often need to have those removed from their record because they're unable to obtain housing, sometimes because of that, as well as they're unable to get a decent job and they have to have it removed from their record. And I actually have experience with one of those. And banking is another thing. We don't think about it, but individuals, there's many people live on the edge. They don't have opportunities and they don't have good credit, and they just found out their check bounced. So if you're a single parent, you found out your check bounced and you're losing your housing, you're maybe living in your car, all of these are interconnected. We do have something in Washington called Bank on Washington, where they can give help, to individuals that need assistance rather than having to always turn to, predatory lenders. Next slide, please. So as I mentioned, or I didn't mention, the competing, all of these competing factors actually add to the stress and trauma. Of course, if you have a health visit, a clinical visit, it's even more, right? And there's prioritizations as far as what you can do each day. And when something is answered, right, that challenge goes down, but something else usually comes up. And I just want to say, I chose this graphic. It was from the Kaiser Family Foundation after searching through many, because I appreciated they showed racism and discrimination. As we know, during COVID-19, this is really been come to the forefront of everybody. And there's ageism, there's ethnicity, there's income, there's so many forms of discrimination. And a National Academy of Medicine paper just came out yesterday about COVID-19 and assessing the disparities. I'll put it in the chat later. But basically, I like what all this includes, because it also talks about walkability. People don't think about walkability, but if the doctor says you need to lose 15 pounds if you walk and exercise, and even to a child, right? The playground isn't safe and you don't have sidewalks. The majority of people don't have sidewalks. Actually, we don't realize it if you live in an urban area or you're wealthier. But the truth is that's a fact. And also stress, it has so many impacts on everything else. And of course, this can lead to at times violence and trauma, right? And we've seen this during COVID. And people will say, you might be able to eat better for your diet, but the truth is they rely on food banks. And sometimes the food that you receive isn't fresh. If you live in Yakima, you might have better opportunities for healthier, fresh food than if you live, say, you're a lower income individual on the outskirts of Tacoma. So, these all interconnect. Another thing is literacy I'd like to address, and access to linguistically and culturally appropriate materials, which I recommend that you have individuals in your clinics or whatever organization you're with, create materials that are patient facing, that are understandable, and mostly by visual, they'll be able to understand what you're talking about, because this really makes a difference. And it's also important if you're able to know what the cost of the care is, right? So many patients have medical bills. It was the #1 reason for bankruptcy before COVID, and it might still be. And I'd like to emphasize this, identify the needs to address, focus on patient-centered care, and recognize individual strengths. I focus on strengths. If you do strength-based queries when you're asking about or collecting and screening for social determinants of health, you'll most likely have a better outcome, as well as strength-based shared decision-making, right? If you know or have a better idea of what your patient's knowledge, skills, and strengths are, you'll most likely have better outcomes. And so trauma-informed principles are something else I'm very steeped in, and I really believe in. Complex care focuses in this area. But if you are facing all these negatives, you're not living in the positive social determinants of health, where health and well-being are. You're in the higher rates of mortality, more morbidity, higher care expenditures, and your health status. There's it just goes on and on. So it's important, and for the trauma-informed principles, the National Center for Complex Care, the Camden Coalition, offers a frontline core competencies training. And if you'd like more on that, you could ask me. But basically, I'd just like to share, understand the individual interconnectedness, as I mentioned. And so telehealth has really brought care to many homes where before it was more available perhaps in rural, but they still need that internet. They need that, that phone to be able to connect with you. But how all of these interconnect and why individuals might not be able to follow through on their treatments or make their appointments is good to know, and how you could perhaps work with them on that. And I suggest mapping a client or patient priorities where you understand somehow, if this could be in your EHR, and I know you'll see it in the next few years, maybe sooner than later with interoperability, but patient priorities should also be taken into account. And something I really recommend is that patients, if you could ask if they have photos of what they're living with or what they would like their life to look like. They could find it on their smartphone and they could share it with you, put it in their portal. And if they'd like to show you they don't have food in their refrigerator, or they don't have a sidewalk, or they just had a bad accident, they could also share that with you too, or perhaps something about remote monitoring. So really with smartphones you can do a lot. Next slide, please. So I'd just like to thank you all for being here and take time to reflect on what is and what could be, because we all have the ability to really make a positive difference in somebody else's lives, and we all have bad days, but I think we all should like to be the change that we'd like to see. So thank you.
Thank you, Janice. I really appreciate you being here and sharing your story with us. I think it's a great reminder that the social determinants and social need aren't just boxes on an electronic health record screen, but they really are people's lived experience. And because of that, a lot of that can get really complex and interconnected with things like racism and discrimination. And it's really important to be meeting people where they're at when we're talking about social need and equity. Thank you as well for calling out on that last slide, the importance of reflecting on where we currently are and where we want to go. We'll have some time later in this event to break out into some small group discussions and have a whole group discussion about just those topics. So I'm really excited about that. For those of you who don't know me, my name is Nick Locke, and I'm a program coordinator at the Bree Collaborative. And I'm going to be facilitating some of our conversations today as we jump between panel discussions and then our whole group discussion. We're trying something a little bit different today. We're trying to create a hybrid event with some best practices from organizations currently working on social determinants of health, and then jumping into a sort of shared learning discussion later in the event. So I'm going to go ahead though and kick us off by just talking a little bit about what we've done at the Bree Collaborative over the past year to develop some recommendations to assess and address social determinants of health, as well as health disparities, including from racism in clinical care. So the Bree Collaborative really got engaged with this work back in the summer of 2020. I think as most of us, when we were beginning to experience COVID-19 and protests around health equity concerns, as well as equity concerns in greater society, we really were realizing that the time is now to address social determinants and health disparities from things like racism and other health inequities. The Bree Collaborative embarked on a research project that really involved 3 pillars. The first was a literature review to identify key topics and best practices. The second was work group collaboration, where we invited stakeholders from around our state to participate in monthly conversations, identify local barriers and resources, and share best practices. And the final part of that were some key stakeholder interviews, where we interviewed around 25 to 30 organizations on what their current interventions were and how all of those would work together. From those conversations, we developed a sort of 5-step clinical recommendation framework. And I'm not going to be able to really dive into that as much as I might want to today. I highly recommend that you look at the Bree's recommendations on our website. I just sent that link in the chat to everyone. But basically, we were looking at these 5 areas as the sort of focus areas for how to address social determinants and health equity. These focus areas include planning, which must involve engaging patients and healthcare leadership, trying to develop some level setting and buy-in, identification of not only social needs, such as housing security and food security, but also race, ethnicity, and language, as identified by your patients or clients, developing some type of tracking and measuring system, which would include interoperable codes, plus potentially registries, so that we're able to use this data for improvement. And then developing those follow-up steps, linking to care coordinators, working with social service organizations to try to meet patient social need. And while they're displayed here as sort of a linear progression between those 4 domains, we understand that they're really all happening at once. And while you may be able to have the capacity to develop a screening tool for social need, you might not have the capacity to develop follow-up steps at this point. And then underpinning all of those 4 focus areas are incentives and investments, including reimbursement mechanisms aligned with value-based payment, as well as emerging technologies that can be invested in, or also can have better standards developed for them, including community information exchanges. And while those were our overall 5 focus areas for recommendations, we also developed 3 next steps to continue working in this space. The first was an ongoing coalition to continue to aggregate emerging best practices and also disseminate those findings to local stakeholders. The second is a data registry to be able to collect that data in an interoperable way and use that data for improvement. And finally, we wanted to focus a little bit on some systems transformation pieces, whether that's developing resources for local pilot projects, or also partnering more with community-based organizations to expand their capacity, because we know that this isn't just a healthcare issue, this is also an issue that touches multiple sectors. And so while our initial work, really, we just tried to wrap our arms around this incredibly large topic, we're hoping that throughout 2022, we can help turn some of those recommendations into action. And so I'll be talking a little bit at the end of the event about what some of our plans are for 2022. But before we get to there, I do want to highlight some of the organizations that are already turning recommendations into action and already developing pilot projects to address and assess social needs in their spaces. So to begin, I'd like to invite up Ton Thompson and Dr. Brendan Smith from Family Health Centers, who have prepared a short presentation about their thinking around social needs and how they were able to implement some new pilot projects in their clinical space. So I'll go ahead and stop sharing my screen for Ton.
Welcome. As I get this up here, I'm Ton Thompson, the team-based care director here at Family Health Centers. We're in Okanagan County, so central of the state, up on the border. I actually live in Orville, like I overlook the Canadian border, which just the opening up the last couple of weeks has made more traffic than I've seen for 2 years. So it's been pretty fantastic. And then Dr. Smith will also be doing this, and I'll be presenting the slides here now.
Perfect. Hello, everyone. I'm Dr. Brendan Smith from Family Health Centers. I'm a naturopathic physician by training. I'm in practice here at our federally qualified health center, as well as the director of clinical quality. So this is a process we've been involved in for a few years now. But as you can imagine, everything with COVID sort of highlighted these issues and really showed kind of how much of the social structure behind our patients really determined a lot of kind of their health outcomes moving forward. So I'll go ahead and get started. John, if you want to jump to the next one. I want to highlight a couple of things, what we wanted to do in terms of addressing social determinants of health. We needed to get some perspectives aligned. That's a hard thing to do in a sort of rural health clinic. We have, both providers that, fresh out of residency programs, all behind this. We had some providers who've been in practice for 30 years and saying, this isn't primary care's job. We had other people that said, oh no, our clinics, we've been doing this forever. You just want to have us put this in the system and that's too much work. And then we had people that said, yes, we believe in this. This is so important to get upstream of the health issues in our community. So that's a challenge we have. Getting perspectives aligned, I think everyone acknowledges and understands it. However, it needed to be something that was a non-time intensive addition to our normal flow. I think what we feared the most was a lot of providers and teams saying, this is one more thing. This is one more documentation, one more step. We're strapped already. And now we're supposed to do this. We needed to get buy-in. And so in this process, bringing the social determinants of health to the forefront of care needed to be smooth, and it needed to be felt as a valued service by all staff that didn't put them further behind on already a taxed healthcare system. As you know, we have nursing shortages like everyone else, but again, in a rural community, we don't have many other places to pull from. Our staff often, we train them here locally, coming out of, they come in as MACs, maybe training, was sort of all done internally. And the only other job they held before this was working in the packing shed before they got in the healthcare system. So there's a lot of onus on us to really build our teams up. And so that was a big piece for us, is to say, how can we make this part of our normal training, but not overly burdensome on the folks that are just trying to get all their skills down. We also know that, implementing this as a screening at every single visit, our staff said nope. they were not interested. They looked at the Prepare tool as a full tool, and it was scary. We also don't necessarily have the nurses and teams that were able to roll this out with every patient in a way that we felt kind of maximize the patient's engagement. Last thing we wanted to do, honestly, was collect this and not do anything about it. That was a big issue to us, is that these are data points, sure, but if these are data points without helping someone, it almost felt wrong. So we really want to make sure we had a good Luckily at Family Health Centers, we've been really pushing.
Someone's dog growled.
Oh, sorry. I don't think that's my dog. We've been pushing on team-based care initiatives and working on that transformation. Ton is sort of helping lead that transformation for us now. And that gave us a rare moment in time when I think that we had the opportunity to rethink care delivery. We looked at who's in our team, what does an actual team look like for a patient, who's involved, and we sort of capitalized upon that piece of it for implementing more social determinants of health work. And then finally, again, action-oriented intervention. If we see something, hear something from a patient, we want to do something about it. And so we'll kind of walk you through our process and kind of go from there. So a lot of background. I don't know if anyone else is on the Google platform, but we use these Jamboard sessions during COVID like they're going out of style. Sticky notes, we could cut, paste things. We use the Athena EHR, and they also were sort of implementing different social determinants of health sort of screening workflows. One of them was being that they integrated some of this into their social history. Had sort of those prepare questions in there. Then they switched over on us and went to a full screener. And then we found sort of deficiencies and sort of pros to each of them. And so just to kind of highlight what we really came down to was we needed to have a sort of subset of digestible.
Sorry.
Sorry.
Oh, nice.
Oh, we have someone else.
Thank you. Appreciate it.
Maybe getting coffee. Anyways, we had to come down to sort of digestible ICD-10 codes. And so as you can see, extreme poverty, low income, insufficient social insurance welfare, other problems related to housing. You know, those are some of the ones that we knew were going to be primary drivers, especially around housing and poverty in our area. We worked on pulling in different people into this process. So our call center, that little yellow box, we know that they hear a lot of this. They hear this on the phone with patients. I can't make it to an appointment. My son's got to drive me. Or, you know, I'm sharing the car with my kiddo who's working up at McDonald's and he got called in for an extra shift and I can't get to my appointment today. So we really wanted to find ways to get our call center involved in identifying this, because a lot of the social determinants of health, we hear them, we just don't systematically collect them. From there, once the patient's in the clinic, we know that our medical assistants, our case managers, and also our sort of new team of community health workers were going to be sort of prime team members who would be able to both collect this information, but also they just know our patients better. They're born and raised in the communities that we serve in this rural system, and they often kind of hear those discussions. And so we wanted to empower them to kind of make a change that they could populate these onto the problem list. Prior to this, it was a provider-driven only problem list. And we had to make the decision that as a team, we wanted our MAs and community health workers, case managers, call center staff to be able to identify housing or other problems and actually put them in the system. So that was a great step for us. Tony, if you want to go to the next slide. And again, just showing you more and more. So we had lots of iterations on this thing, trying to figure out the processes, bouncing back and forth within the system. If anyone's implementing this, something to know is reporting on a prepare. You know, in our EHR, it was really difficult to do that out of the screener. We actually had a better shot at doing that through our social history. We knew that the entire prepare was too much. And so I essentially rewrote our intake forms, and I just sprinkled in essentially a few screeners on housing security, food security, safety, you know, and really sort of looking at those. We collected other demographics that helped us identify these issues. But if we found those in the social history intake, it could then prompt our team to make a referral to someone like a community health worker or an MA to kind of finish up the screen or do a full prepare. And so that really, I think, became a standard for us. And we'll scroll just through the next 2 slides, just showing you again our process. It took a lot of back and forth, a lot of sitting with stakeholders, sitting with MAs, sitting with community health workers, talking to everyone, building this out in the EHR. Lots of different real world things that you want to dedicate the time for that we found. And we're still not perfect yet. So again, we kind of started just with the idea of, can we implement social determinants health questions from each domain in a way that matched our current clinical workflow and didn't feel like a burden or one more thing, that it just invited more conversation between various team members and our patients. Kind of moving on from there, we really sort of capitalized upon a community health worker support system. And we've been implementing more and more community health workers into our clinical care teams. And they've really become this team member that, one, is attached to our outreach. They know the different community resources. We participate quite a bit in our local CHI, so the Coalition for Health Improvement in Okanagan County. And by essentially kind of tying all these services in, our providers were saying, I have to be a provider and a social worker. They don't have the capacity to know how to connect patients with all the community-based organizations and resources and everything that we would identify here, and screening for social determinants of health. And so it really was a huge boost, I think, to our ability to kind of produce this. Not all of our providers are on board, but if our teams are empowered, our teams, I think, are able to identify these issues and take action. I think a lot of other folks sometimes feel a little bit overwhelmed by, what do I do about housing for this patient? We then have to take these issues as family health centers, as FQHC locally, and go back to our try and advocate for these needs. So then the last stage that we got to was really looking at the social determinants of health, running these through. We're a fairly kind of mid-sized to small FQHC, rural FQHC. Kind of after the process of doing this, we found that, we collect about 950 sort of distinct housing questions out of our prepare screening sort of tools or questions that we dropped into the intakes. We learned about transportation security as well, and whether or not people were physically and mentally safe. And even though we haven't asked every question on the prepare, I think that these really started to open up conversations with patients to delve into more of the details, and also creating pathways from a provider team through a community health worker to community-based organizations and resources locally. And I think that was a major win for us. So that was the how. And then to the last one, the why. I used to work with Victor Montori from the Mayo Clinic. We used to teach evidence-based clinical medicine, and I steal this style from him. He always focused on a patient and built the entire story around them. This isn't a diabetic patient. It's a Carlos, and Carlos has diabetes, but he's got all these different issues around that we have to address. And so we have a sort of diverse team. We know that, everyone from our call center through our, sort of front desk and to the provider and then the MA or whoever's walking the patient out the door, that we need to be able to address these needs across the board. So we're really taking social determinants of health and try to support that through various grants, kind of braiding all those resources together for common causes, really working on our community partnerships. I myself, as a provider, just went and taught a nutrition class in a school a couple weeks ago, knowing that, those are the things that we have to do to kind of help, combat things like obesity and type 2 diabetes in some of our communities. And we have to support our schools as a federally qualified health center to kind of get ahead of these things. And then finally, just making sure our staff's there and, using the data for improvement. I found that when we can tell these stories and attach the story of the patient to the numbers, it's really impactful for our teams. And I think that that's going to motivate them more to ask those questions. And we hope to sort of move forward. I know Ton's working with our community health workers on, motivational interviewing training and really helping them figure out how to kind of connect even better with our patient population and figure out how we can address these on a larger scale. So, and we'll go to the last one there. I'll say for family health centers, it's not perfect. We're still going. As a director of clinical quality, I like to say that it's never perfect. So you have to keep adapting, keep changing, keep testing. Our EHRs drive some of that. Our internal processes and team makeup will drive some of that. But I can say that the change that we've seen has been pretty dramatic. And it's great that even for the folks that maybe, or the providers that feel like this is too much for them, our teams around the patients are helping carry that in such a way that I think a lot of providers feel more supported. And it was really the burden of trying to be a social worker for our providers was the biggest barrier. Once they see this happening, they love it. And I think it just means that they start to utilize their team members to sort of help our patients get the best foot forward in life so that they can focus on their health and not make, negotiations for themselves about, whether or not they're going to buy this food or they're going to, get an eye exam done for the fear of cost. So it's been a great learning experience. But I think I'm over my time. I apologize. I hope that was helpful for people to see the nuts and bolts of what we did. And we'll talk more about it in the Q&A.
Thank you, Dr. Smith. I really appreciate how you were sharing some of your planning thinking with us, and it really highlights how we need to engage everyone from call center staff to the providers who are asking the questions. And I think it's also a great example of how we need to think creatively. For example, there's barriers that come up about the questionnaire being too long or how will it fit into clinical workflows. And it seems like there was some great problem solving, fitting that into the intake paperwork, starting small, kind of making the proof about why this is important. And so I appreciate you sharing with us. And for everyone else too, we'll be able to have a time to ask questions in our Q&A portion a little bit later. But first, I'd like to invite Tricia Freely from Virginia Mason Franciscan Health to share some of their experiences implementing social determinant screening in surgical outpatient and then in primary care.
Great. Thank you, Nick. And you have my slides, right?
Mm-hmm.
Okay, great. I am here also with Allison Bradywood, who is our Vice President of Nursing and CNO, and Norris Kamo, who is our Medical Director for Quality for Primary Care, who've been involved in this work. My role is Senior Director of Ambulatory Services, focusing on our primary care services at Virginia Mason Medical Center, which is one of the medical centers now under the umbrella of Virginia Mason Franciscan Health. And we just wanted to share our brief overview of our journey of incorporating social determinants of health into our care. And I think, a caveat to this, we very much feel like we're infants in this work. We learn every day and we try to incorporate that learning into our next steps, but we feel like there's so much more to learn than we have mastered so far. And we haven't really mastered that much, but we are excited to kind of share this with you, and I'm really excited to hear the conversations as we want to continue to improve how we incorporate this into our care. All right, you want to go to the next slide? So this, I know we're all on this call and we know this, but 80% of health and well-being is related to how and where we live. And this is, to go back to the why that from the previous presentation, this is really where we know we can make a big impact if we focus on that 80%. So kind of anchoring on that why as we move this work forward across our system. Next slide. I just want to touch on some of the pilot work that we did, and the pilot spurred on some in-between work that is just our journey that we're on right now. In 2019, we had a small pilot in several surgical sections that really just started the groundwork around this. From that, we worked to build tools and workflows that we could incorporate on a larger scale. And then a lot of work was to incorporate our SDOH screening into our EMR. And so I'll talk about that a little bit. And then in 2021, so this year, primary care, we had a pilot that we ran with a targeted population, our population with an A1C over 7. With that, we really focused on how do we refine processes and tools for our ambulatory flows in patients in the ambulatory environment. Next slide. So just to touch on our surgical section pilot that we had a couple of years ago, our goal around this is to, we wanted to, with the screening, understand patients' needs before hospitalization. We wanted to get to a point where we routinely are addressing social risk factors that could impede health, and with the overall goal of reduce financial impacts on the healthcare system through reducing length of stay and or readmission rates. So the process was pretty paper pencil, and how do we kind of hammer this out? Our patients were screened for SDOH factors on the pre-surgical visit, just using a paper form. We used that paper form because it was iterative over time as we were just finding the right tool to use and the right way to be using it. Once those forms were filled out, they were reviewed by an RN. The medical assistant collected them, and they were reviewed by the RN. And then depending on the responses, the patients were directed or connected to appropriate resources. And in the beginning, we weren't really sure, and going back to the last speaker again, we didn't want to collect this information without doing something with it. And so in the beginning, we weren't really sure where we were going to direct people. And we built out that process over time as we got the information in, and really thinking about where's the best place to direct a patient with X, Y, or Z needs. All right, next slide. So some of the outcomes and key learnings from that pilot was we, over that iterative process of the paper form, we came up with a standardized tool that we use and now is in place, and has been incorporated into our EMR. We worked through a couple of different workflows around how do we administer this. And a lot of our workflows for rooming a patient is the medical assistant asking the patient questions. And what we found is we got more reliable results if we let the patient fill out the form independent without asking them these questions. So really just looking at how is the best way to gather this information. And I just spoke to this as more elements of the toolkit were developed. It took less time and staff resources than originally anticipated to provide helpful interventions. So it was less of a referral to social work and more, here I have some information that can help direct you in the right place. And then what we were gathering around that is individual patient stories indicating benefit. And then from that, there was a likely decrease in stay in some of those stories, but we really don't have enough data to understand that correlation yet. So that's part of our ongoing work, but that's what we're hopeful to see over time. Thank you. Next slide. So this is the screening tool that we used. It's 7 questions. This was on the surgical side. So some of these questions are really focused on can you care for yourself after surgery? And that was a quick and easy tool where we could get at the key components that would be impactful to a patient's care. Next slide. And then this is some of our work to incorporate it into our EMR. So we modified the SDOH screening tool to work within all settings. So taking out some of the language that just pertained to the surgical setting and made it appropriate for the ambulatory setting, the inpatient setting, procedural settings, and in the emergency department. And we incorporated the tool into our EMR as discrete data elements. So over time, we can collect that information. Our EMR is Cerner that we use, and we were able to put it in our banner bar. So it's front facing every time anyone on the care team opens a patient's chart. And it will either say SDOH not, in this example here, it says not documented, which means we haven't collected that information on that patient yet, or it will say risk factors present. And so it will be an indicator to the care team of needing to look a little bit deeper and consider a little bit more around that patient's care. Next slide. And then we really worked after that surgical pilot to build out our toolkit for resources that were specific to these areas where we were seeing patients needing assistance. And so have built a really robust toolkit that is in the hands of our care teams to be able to help our patients. Next slide. So our pilot in primary care this year was, our goal was to understand the needs that could be impacting patients managing their diabetes. And then to understand different methods of collecting SDOH information in the ambulatory environment that wouldn't add an additional burden to our teams. And then to understand effective ways of providing interventions in the ambulatory environment. Again, being really mindful of our people resources that we have and how to best utilize them. The process that we have used on the primary care side is we send the questionnaire out through our portal, through our MyVM via an e-clipboard to patients who have an A1C that's greater than 7. Patient charts are reviewed for the completion of the SDOH questionnaire and scanning for positive results. And then positive results are cataloged and appropriately referred. So then we have that referral piece on the back end. Next slide. So some of our outcomes and key learnings. So we, in this pilot, we have collected data for 1,600 patients. And about 14% of them had come back with positive risk factors for SDOH elements. So from that, we found that the use of the comprehensive toolkit was adequate to address about 70% to 80% of the positive responses for the SDOH factors. And it was merely getting that patient connected with those resources. And then another 20 to 30% were appropriate for a referral to the social worker RN to further assess what was going on at the time. Another, you may have seen in our process, we used a push out through the portal. So collecting this information wasn't attached to a visit. It was asynchronous from a visit. We have about 80% of our patients who are using the portal. So it does look like a reasonable way to automate portions of the SDOH screening, but we're needing to continue to use other methods to ensure that we're connecting with everyone. But this was a way that we could automate part of the process, gathering that information. So we were encouraged by that. And again, we have individual patient stories that indicate benefit from the work that we're doing. So we think we're heading in the right direction around that. Next slide. So this is just some of the outcomes from our primary care PDSA. So that high spike in the middle is question number 4, and this is relating to money for your medication. So just with this, we have a really good idea of for this patient population, what is the biggest thing that we can focus on to make an impact in their care. And then you see the other responses below. Next slide. And so this is just our dashboard that we're populating with our now incorporation of the SDOH data elements in our EMR, which over time is just going to provide us with a wealth of information about how to think about populations and how we support them overall. Next slide. So future work for us, like I said, we really feel like we're in the beginning stages. We want to expand the processes, of course, to all patients in all environments. Again, the previous speaker, this is on our minds too. We want to think about the appropriate frequency to be collecting and updating social determinants of health information in the different environments. I think it can be different in each environment. And we want to continue to track positive factors and outcomes at the patient level and at the population level to understand the effectiveness of our interventions that we're putting forward and where we may need to do further program development. And then we want to ensure that we continue to incorporate SDOH into our organizational diversity, equity, and inclusion initiatives overall. So we just have that lens and that true north that we're working towards around that. And that, I think, is my last slide, Nick.
Thank you so much, Tricia. I really appreciate and I'm really impressed with VM's capacity for integrating all of that data on social need into the electronic health record, being able to pull it up for an individual patient. And also overall, I think that's a great example of being able to use that data for improvement and for specific patient care. So now we're going to go ahead and move into our Q&A with our panelists. And so I'll invite Tricia, Dr. Smith, Janice, and also everyone else who was involved. So Ton, Norris, and Allison, if you'd like to join as well. I'll go ahead and stop sharing my screen. And for everyone who's attending, please feel free to enter your questions into the chat and I can go ahead and read those out loud. Or if you would prefer, you can raise your hand and ask your questions directly. So I'll go ahead and start. It looks like we have a question from Michelle that's asking if there are any suggestions for small groups that don't have maybe a social worker or a care coordinator on their staff specifically.
So Michelle, we're a small organization. We have 6 clinics around the county. We have really filled that role in with what we're calling community health workers clinical. And as Dr. Smith mentioned in the presentation, we are hiring people that have worked in the packing shed or the last job was in retail at either Amazon or one of the fast foods. And we're putting in a training process and getting people, like we're using the Department of Health from Washington State, their community health worker certificate. We're training them as MARs. And then we have a series of ongoing internal trainings. We've hired 25 people in the last 3 months. 17 of those are doing this sort of work that will include the social history. So I hear you, and it's a lot of work, and we'll have more information next year on how well this is working for us.
I want to highlight something else, Tom, just kind of based on, I've been with the organization almost 5 years, going on to 5 years. And I can tell you that we did some training, community health worker training with MAs, but I can tell you that hiring people as community health workers who are coming in with that lens first, and then who go into doing some of the training around MAR work is a different process. And I think it's been great for us to actually have people coming in who really want to be in that capacity of a community health worker first, and then do that training. I just have to say that there's a difference in that staff engagement and all of this kind of based upon how they entered the healthcare system.
This is Janice, and I just wanted to mention that 2-on-1 is statewide, but if you do refer individuals to 2-on-1, just please inform them that the wait times can be very long, and that often the resources that they might help them with have very very close parameters, like certain hours are open or qualifications. So, but 2-on-1, you can also look at they have a written directory as well that you could advise them to look at.
Yeah, I also think it's important to highlight that while it is great to have the social workers and care coordinators on board, and that really helps create a closed loop referral, there are some sort of lower tech ways to create referrals, providing internal referral lists. It looked like VM had a set of referral lists for the questions that they were asking as well. Maybe kind of treating it like you would specialist referrals, have a list of priority organizations that you've referred out to and heard back good things from, and just keeping a list of those. I see DC Dugdale, you have your hand raised.
Yeah, thanks, Nick. DC Dugdale, UW Medicine. Question for, I think, Ton or perhaps Brendan. First, two questions, pretty small ones. The first is, I'm going to clarify if you're allowing the community health workers to add things to the medical problem list. And then second, do you use patient-reported categories regarding economic limitations? I mean, I saw several things like extreme poverty, insufficient income. There are 4 or 5. Do the patients report that, or how do you validate that sort of information? Thanks.
So be happy to take that one. So on the problem list, that was a huge contention point at first. And so what we did is essentially the community health workers identify that, and then with the provider say, yeah, okay, we're going to add that to the list. It just kind of helped bring it to their attention, but it was identified by the community health worker. In terms of the patient demographics, I mean, we pull their income data off of their initial intake work. And so there still is that question about kind of self-reporting in terms of, we do have those questions on inability to pay for like medications within the kind of larger prepare tool. And so we might find specifics there. So we base their income off of their intake paperwork, but how they self-report, we can see whether or not it's congruent with what we have in our system.
Okay, good, thank you.
I see another question in the chat from Carrie asking if any organizations that are either training up community health workers or MAs from non-medical backgrounds have seen an impact on infection control, vaccine hesitancy.
So I don't know about infection control. I do know our infection control nurse is very on top of keeping the procedures and policies correct. And we have a competency checklist for the MARs that we're training from the community, that they are not allowed to do the job on their own until they have passed those competencies and have their initial certificate from the Washington State Department of Health. But it is definitely a concern that we are aware of and tracking. As far as the vaccine hesitancy, because we've done the majority of our hiring since the Washington State mandate has gone on for these positions, and we just don't have candidates that they have to be vaccinated. It's a non-issue for our new employees.
Tony, you might want to mention as well, I think in terms of vaccine hesitancy in the community, the impact of having those community health workers, I've been there to kind of host a couple of the larger vaccine events in our county with you. And we have community health workers there participating. So do you want to speak to kind of their role in that capacity?
Yes, so we've hired a team. We had a grant for vaccine outreach. We've hired a team of 6 community health workers that are outreach specific, and they are taking the mobile unit and going out to our community and at events. For example, they're doing Operation Christmas right now. I was just asked actually during this meeting to approve a PO for a Santa suit. We're going and trying to build trust in the communities. We're at where the communities are, have an event on Main Street for getting vaccines in. And this is an entire team dedicated to that work at this point. And then I also see about childhood immunizations from Carrie. Do you want to clarify that question?
Sure. Hi, Ton. I'm just curious, in doing some of the social determinants of health work, I think sometimes, well, social workers and community health workers are more in tune with the social determinants of health. Sometimes figuring out how to deploy them, where to deploy them, when to deploy them can affect other sort of the medical side of things like immunizations and vaccinations. And I'm wondering if you guys are running into that problem, or if you're using them to like address low vaccination rates in certain, like you're using your social determinants of health information to identify low childhood IMS vaccinations or something like that, and using community health workers to improve it. And has that worked?
That's a good question, and I'll let Dr. Smith answer to a certain extent to that. But I can tell you, we have just hired this team in the last 6 months, and I'm still doing interviews. So I think I'll have better answers for you in a year.
And I can say, unfortunately, we don't have a ton of data to really back this up yet. I mean, it'd be publishable work if we get to that point here to really be able to kind of boil that down. I think with our community health workers, and what I can tell you from our quality measures when we look across the board as an FQHC, working in a rural county, our sort of non-Hispanic, Caucasian, socioeconomically depressed population performs the worst in the county on several measures. We've learned with our community health workers as well just how much trust of the healthcare system also plays in. It's been interesting. Our team of community health workers, again, are sort of representing, sort of different demographics of our community in Okanagan County. And so, overall, my hope is that we're going to hear more and more from them about why we see, lower utilization of childhood vaccination rates in different populations in our county. We just have to watch that over time. But if the vaccine hesitancy for COVID has taught us anything, that it's primarily a mistrust of the healthcare system. And we sort of see that. And so getting those community health workers out there is a big, part of our hope to kind of build that trust, is that they will connect with the community leaders that might carry more trust than the healthcare providers. As myself, I moved into this area as a healthcare provider, born and raised in Seattle. I'm not trusted the same that someone's going to be trusted who is the son or daughter of, a family that's had an orchard for 3 generations. And so our community health workers, I really hope, are going to be one of those keys to kind of building a connection. I call it the bridge over the quality chasm for us is probably that trust.
Thank you so much, and thank you for all of the questions. I unfortunately will need to cut us short so that we have time for a discussion with everyone who's attending here for our last half hour. But I really think some of those pieces that we're talking about at the end there about community trust really play into social determinants as well. I noticed Janice put a comment in the chat about making sure that we're not creating re-traumatization or overburdening our patients. And I think it's important to remember that there could be mistrust when we're asking about their social needs as well. And so I'd love for us to just sort of be thinking about those and our other questions as we jump into the discussion portion of the event. So I'm real quick before we jump into our first breakout session, I just want to talk about what we're doing here. We're kind of trying something different, trying to encourage conversation and peer sharing in this event. So thank you for bearing with us and being willing to participate in some further discussion with everyone else here. We're going to go into 2 different breakout sessions that we're going to structure along the lines of sort of what Janice was mentioning earlier. First, what are we currently doing to address social need and health equity? And then how can we better integrate social need and health equity into our healthcare organizations? I'm going to go ahead and go pretty quick through our first section so we have enough time to discuss. Just to set up our first breakout session, I know that this was also in the VM presentation, but we know that social need impacts health outcome even far more than healthcare services do. healthcare services contribute between 10 to 20% of health outcomes, but those factors, health behaviors, social and economic factors, genetics, physical environment, really play a big role in a lot of our healthcare outcomes. And even though we know this, we know that we're not currently integrating social need and some of these other health behavior factors into our healthcare services. And one of those reasons is that there's a good amount of legitimate concerns about integrating social need into healthcare. I've listed a few that we heard in several of our key stakeholder interviews at the Bree, including some people just don't believe that that's part of healthcare's role. Maybe there are some capacity issues with electronic health records and the data burden of adding another thing to workflows. There might be capacity issues with not only healthcare, but also social services if we're expecting them to take on a greater number of clients from all of these referrals that we're hoping to make. And then we know that there are some limitations about what healthcare dollars can pay for, and are we able to fund more social workers or more community health workers in order to address some of these social needs. So for our first breakout session, I'm going to go ahead and break us into groups of about 6, and we're going to break into breakout sessions for about 10 minutes. And our first breakout session is going to focus on what are we currently doing to address social needs and health equity. Amelina is going to copy paste that question into the chat, so it will follow with you as you go into your breakout session. And another thing that we're trying out here is that in the chat, there's also going to be a question to assign basically a scribe for your group. That will be someone who can take notes during your group discussion and feel comfortable to share out when we come back to whole group debrief. If your scribe, if someone is really interested in being scribe, feel free to also volunteer for that position. And while we have this main question that we're going to look at during this first breakout session, I'd also really encourage you to kind of drill down into some sort of sub-questions. If your organization currently isn't doing or isn't implementing any interventions to address social needs, maybe consider discussing what stage of change you're currently at. Is your organization in pre-contemplation? Has your organization leadership considered change, but just isn't to that step of enacting change yet? Also, what are some of the perceived barriers and facilitators for your organization's context? I think that there's a lot of common barriers, but there's also some barriers that specific organizations might face that others don't. And I think it's really important to be able to learn from each other and see what's going on around our state. So I'm going to go ahead and set up 4 breakout sessions, which means there should be between 4 to 6 participants in each breakout session. We will have a staff member jump between the breakout sessions in order to sort of make sure that everyone's questions are being asked or everybody's questions are being answered and everyone feels ready to join in the conversation. And of course, if you are unable to continue going, or if you have any additional questions, feel free to rejoin this main room here. I will go ahead and stay in the main room to answer any questions and help facilitate as needed. All right, I am opening those breakout rooms now. You should be automatically sent there, but if you are not automatically sent there, you should have an option in your toolbar sort of near the share screen option to join the room as well. Welcome back to the main session, everyone. My apologies for some of the confusing messaging in the breakout sessions. I'm sorry if we weren't able to get enough time to really dive into the discussion. I just really want to have enough time to open up our second breakout session as well. But before we move into our second breakout session, I'd love to hear from the groups and hear a summary of your conversation, see what you were talking about. Would anybody like to share what their group was discussing?
I can jump in for group 3. We were discussing just resource guides and how much time it takes to actually put those together and some of the best practices, as well as just, you know, the communication and coordinating efforts versus all these different clinic systems, everyone sort of recreating the wheel over and over and over again and sort of trying to figure out how to bring those together. I also want to apologize. I'm not on video, everyone. I'm injured and in my basement, and it looks a lot worse on camera than it does in the real world. So sorry I couldn't present to you there. So you'll see all the pipes above me. It's not pretty.
Thank you, Dr. Smith. I'm also noticing that we have a question about if you would be willing to give out your contact information. And so feel free to connect with me after if you are willing. But
No
from
problem.
groups 1 or 2, would anybody like to share what you were discussing?
Sure, I'm not sure what group number we were. I mean, it all moved too quick. I think we had 3 of us partaking in the conversation, and I think it was identified that one of the members of the community health side, clinic side, and how they've been working on this. It's natural for them, but it's still very difficult finding resources to do this, especially when it comes to housing and things like that. Some of these things are outside of our control as much as we wanted to do the resources. And then I think we identified a little bit just trying to understand how we intake the patients. And that, yes, we're still doing that, just doing it in paper at this point because maybe our electronic charts haven't caught up with what we need to really be reporting and how we present that back to providers in order to be aware of it. And that was my input there was absolutely as a provider, you have to have it readily accessible because you're dealing with five chronic diseases in a 15-minute period. If you don't have a little chart to say, oh, this person has these needs on the social determinants indexes, we're not going to do that very well. That was a brief conversation.
Yes, I know, definitely brief. Thank you for sharing, though. I really appreciate hearing how everybody's sort of thinking about the same things. How do we standardize some of these processes? How do we make sure that we're not reinventing the wheel? How do we really connect to resources that are probably already out there, but it does take a lot of clinical time to develop our own resources? As we move into the second breakout session, I have a few slides to highlight some of the emerging technologies. I'm certain many of us are well aware of community information exchanges and the promises to create some bi-directional information exchange, closed loop referral management, and really hopefully streamline those solutions, as well as I hope we're aware of the Gravity Project and their work to develop some interoperable coded data sets to help us code for social need in our electronic health records. And while I know that these emerging technologies are very promising and gaining a lot of traction, there's also sort of a Wild West nature to this space as we're thinking about what are the standards here and how can everyone share in these technologies equally. I also just want to highlight some of the culture change that's behind the renewed interest in addressing social needs. We've seen articles about COVID-19 and health equity, as well as the increase in social needs from the pandemic. And we know that there's going to be potentially a large increase in evictions as the eviction moratorium ends in Washington state. And so as we're thinking about some of that culture change that's really highlighting the need for this work, how can we integrate some of these new technologies to integrate social needs and equity into healthcare in our organizations? I'll go ahead and split us into breakout sessions again. It sounds like last time wasn't as much time, so we'll try to stay in this breakout session until the very end, so around 12:28. So I'm going to open the rooms again. You should be in the same room with the same people, so hopefully that helps with your introductions. I will see you all soon. Welcome back, everyone. I really appreciate everyone sticking around to engage in conversations with your peers. I really appreciate you being part of this conversation and staying through the end. I know it's a busy time for healthcare with new variants coming out every season, as well as a busy holiday season. Happy Hanukkah to everyone who's celebrating and happy holidays through the end of the year. I'm going to go ahead and just close this out with some next steps. First off, I just think, I know this is a simple slide, but I think it's an important reminder as we go off from today. It's important to remember what we learned today, and we'll share some of the slides and some of the best practices that were discussed in the breakout rooms. I think it's just a good idea to study one, research up on the things that you learned today but might not be familiar with, share one with a colleague or a supervisor, and then try to start one at your organization, whether that's a small, adding a question to an intake form or trying to screen maybe 2 patients or 10 patients per day. And then I also want to highlight some of the work that the Bree Collaborative is doing. We're working in 2022 to turn our recommendations into more of this action, to make sure that we don't have to reinvent the wheel with every topic, but try to create some standard resources for implementation recommendations. And we're going to start that all with a steering committee formation throughout the first few months of 2022, which will include healthcare, social service, and patient representatives. And it would be really great if those of you who are able to be here today would like to be a part of that future work. I see that we're at the end of our time, but I really encourage you to send us questions or stay involved with our future work, especially if you're interested in being a part of our 2022 work group conversations. You can email me directly at nlocke@qualityhealth.org, or you can email the Bree at bree@qualityhealth.org. Again, I appreciate you all staying for our conversations and our breakout discussions, and I hope you have a happy holidays. Thank you.